Greetings, and thank you for joining us today as we look at the effects of COVID-19 on healthcare workers, including physicians. Including in this presentation will be an overview of the important research that Dr. Kristin Tugman has conducted on this topic. Next slide. VITAL WorkLife is a national behavioral health consulting practice focused on well-being in the workplace. Although our organization is really over 40 years old, for the last 10 plus years, we've developed a niche in the US healthcare industry with specialized groups of coaches, counselors, and consultants who are passionate about helping physicians become their best selves. Next slide. We ascribe to the wheel of well-being at VITAL WorkLife. It's really the framework we use to evaluate distinct areas of life and build well-being. And it's infused in all of our processes and solution offerings. Next slide. So I want to introduce our presenters today. Dr. Kristin Tugman is the Vice President of Health and Productivity Analytics and the consulting practice at Prudential. She's been in the health and productivity consulting field for 20 years, and her team at Prudential is responsible for analyzing lost time and designing and implementing solutions to help clients maximize their productivity. Dr. Robert Leschke is a board-certified emergency medicine physician. He currently practices at Madison Emergency Physicians and serves on the department peer review committee, the hospital-wide multidisciplinary peer review committee, and works with physicians on performance improvement. He's also a VITAL WorkLife peer coach, receiving his certification from the Coaches Training Institute. As a coach, Dr. Leschke helps other physicians increase self-awareness, identify personal and professional values and sense of purpose, and align personal values with professional duties. Next slide. Just to cover a few housekeeping items. There's going to be time designated at the end for Q&A, but you can certainly be submitting your questions throughout. And if you look on your panel that offers you a variety of different options, you'll see that there's a question feature, and that's where we would suggest that you put your questions. The webinar is being recorded, and we will be emailing it to you after. It will also be available on our YouTube channel. We're going to be conducting a couple of polls throughout the webinar and encourage you to participate. And then also I want to let you know that contact information is going to be shared at the end of the webinar, so that if you have questions that aren't answered or things that you would like to discuss more privately, you'll be able to do so. So here comes our first poll. We want to know who's on the call today, because that helps us, I think, direct our information. So if you can choose one of the following, and I realize you may actually have a few different roles, but maybe if you can click your primary role, then we'll let you know the results, and you will see them as I see them. I think you can go ahead and close out the poll. So, there's something blocking my screen here. So we have 13% that are physicians or advanced practitioners. We have 20% that are managers, leadership, or in the C-suite. 23% that have more of an administrative role, such as HR or benefits. We have 23% that are counselors or coaches. And then we have 28% that have other roles supporting the healthcare environment. Can we get back to our slides? Thank you so much. Next slide. So without further ado, I'm just really excited for Dr. Tugman to share her research with us. And this is fairly hot off the press. So a mental health qualitative study on the impact of COVID-19 on healthcare workers. I'm going to turn my video off, and I see you're turning yours on. And again, thanks for joining us.
Great, thank you. So if everybody could just help me with a sound check, make sure you can all hear me.
Excellent. Sounds good.
All right, awesome. Well, thank you so much for joining us today. We're really excited to be able to share this research. You know, as COVID-19 emerged and we started to really sort of evaluate where we would be from a mental health perspective, you know, we immediately started to worry about society as a whole. You know, we've been in a mental health crisis pre-pandemic. And you know, our immediate concerns were around, geez, you know, what's going to happen relative to mental health, given social isolation, given the fear that coincides with a virus that that has so little information attached to it. And so we knew we needed to act, and then frankly, we started to get some information around you know, scarce PPE and the stress that was happening within our healthcare system, and we really felt like the place that we needed to start from a mental health perspective was with our frontline healthcare workers and our physicians, to make sure that we are caring for the immediate mental health needs as well as the long-term mental health needs of our workers. So if you could go to the next slide. Great. So we kind of started by trying to understand what were we learning from China, and you know, in general, we found that yes, you know, we certainly there were surveys that were immediately put out. I'm sure many of you have seen the AMA article where you know, the Chinese citizens were experiencing elevated stress, elevated depressive symptoms, and anxiety, and we knew from SARS that, you know, if you end up quarantined, you have a much better chance of experiencing post-traumatic stress disorder, as well as anxiety symptoms as well, and depressive symptoms. But we also know that pandemics are woefully understudied from a mental health perspective. So we wanted to dig in a little bit deeper and really start to understand what our healthcare workers were experiencing. So we were able to find some information. You can go to the next slide. And so, you know, those that were in Wuhan and, you know, in the epicenter were experiencing significant consequences and mental health issues. We started to see, you know, again, 50% experiencing depression and anxiety and distress. And so that made us, again, really sort of just validate the notion that we really needed to sort of get into the front lines ourselves and really understand what was happening for our healthcare workers. You can move on to the next slide. I believe we have a polling question coming up. Yep. So we kind of want to understand from you, what's the primary issue your organization is facing with COVID-19? You can select an answer, that'd be great. Team health and safety, revenue concerns, staffing levels, obviously lack of PPE for many was a big one. Patient safety. Yeah, we did see a lot of revenue concerns. Looks like revenue concerns, team health and safety, kind of splitting right now. Staffing levels, scheduling is getting in there. Yeah. Revenue concerns, absolutely. We were starting to see a lot of concern around, you know, would employees be furloughed? And in our work, we have seen that quite a bit. Obviously, it makes sense if we're all only treating COVID-19 and having to step away from elective procedures. That's going to have a significant impact. So yeah, so team health and safety, revenue concerns, staffing levels, kind of our top three. Looks like lack of PPE wasn't as much of an issue. So that's we did see that. What you'll see in our study, we saw definitely on the front line some concerns, but yeah. So can we pull the presentation back up? All right. So from past pandemics, what we kind of wanted to understand sort of out of the gate was what positively impacts mental health outcomes. And as best we could find, again, SARS taught us most of what we knew as the pandemic was starting. And it's really about personal protective equipment, having the supplies that you need in order to feel like you can do your job and treat your patients adequately. We found that, a significant impact was whether or not colleagues contracted the virus, and management plays a huge role in past pandemics. The ability to give feedback and have supports. And so, one of the things that concerned us was the fact that we were starting to hear in the media that, PPE was a concern, that, hospital beds were starting to become, we were fearful of hospital beds being a shortage. And so we kind of felt like, we're getting to a place where this virus is really unpredictable. Folks don't necessarily feel like they have what they need to adequately treat their patients. And so we wanted to dig in and really understand what's management doing, how can we help, and how can we meet the immediate needs of our frontline healthcare workers from a mental health perspective, again, in the immediate and in the long term. So we really kind of dove in and wanted to talk to folks who are actually on the front lines. So if we can move to the next slide. So we actually launched a qualitative study really, really quickly. And, we wanted to talk to as many folks as we could, but we also wanted to get the information out as quickly as we could. So you can see kind of the specs of the study. We had 14 folks that we were able to talk to. We talked to them for anywhere from 30 to 45 minutes. Most of the interviews were telephonic. Some we were able to kind of give some survey questions, and they wrote out their answers. So they were pretty lengthy answers, so we got a lot of rich information. And you can see, mostly nurses. We did talk to some doctors. And so we learned some things that we thought we would hear, and we learned some things that we weren't so convinced that we might hear. And so we think that the outcomes really sort of help us make some solid recommendations to our healthcare partners. So what did we learn? So we're going to kind of, in the next several slides, we're going to talk about the themes of the study as we sifted through the information and analyzed it. And obviously, we found that the nature of the work had changed. We did hear a lot about the shortage of PPE. I had somebody tell me, I've been wearing the same N95 mask for the last 10 days. Obviously, it doesn't feel good. I'm concerned that it's not protecting me any longer. I'm concerned that we'll run out, and we don't actually know the level of supply that we have, or how the supply chain will work. And so folks were really concerned about that. They talked about getting one mask a day. They talked about making sure that they were kind of coming up with creative ways to disinfect that mask. I actually had one physician tell me that he was putting his in a blanket warmer, because he had heard that if you put the blanket warmer or put it in the blanket warmer for 20 minutes, then that would disinfect it. So he was doing that as an extra measure for the day. Folks talked about the shift changing. I don't know what to expect when I get there. It's all very unpredictable. They weren't talked about not being able to take breaks. I think the one person that, talked to me about the fact that, my mouth is dry, cannot wait to get that mask off at the end of the day. Eating and drinking for me is too much of a process. So for my 12-hour shift, I just don't do it. And, they were feeling sort of overheated at times. We're double gloved, we're double masked. We found it was intimidating to come up to the shift and know that I've got to be screened, I've got to sign off saying that I don't I don't have COVID. One of my favorite quotes really was, once cleared, I get a ticket like you would use for a carnival ride. I thought that was really illustrative of the stress and the sort of abnormality of what she was dealing with when she got to work. And, their work changed. They felt like, some folks in the end did have to get furloughed, but some were shifted to the COVID unit, and maybe they had critical ICU training in the past, but maybe hadn't done that for a while. And, folks said, now I'm taking on more critically ill patients. It's just not something I've done. I'm not used to it. And I worry about, my ability to make sure that I'm doing everything I need to do for those patients. And the ICU is mostly COVID patients. They talked about that, normally I've got a variety, and, these patients are really sick. And every room I walk in, I know that I have to be completely gowned up, and that's making it even more stressful. So you can move on to the next theme. So obviously we expected to hear that fear and anxiety were very common. Most felt that, they were more afraid for others than for themselves. Certainly the nature of the work and being a caregiver and really wanting to make a difference and help people. Folks said, I'm 100% convinced that I'm a carrier. I don't understand why I wouldn't have this virus already if I wasn't. And I worry about, my biggest fear is actually coming home and exposing others. The unpredictability caused a lot of anxiety. Don't know what I'm walking into. I don't know what policies will have changed. We're learning something new about this virus every day. And we don't know if today what we're doing is actually protecting us, because we don't know what we'll learn tomorrow. And that was really telling, I thought. They did say that the lack of equipment was very anxiety provoking. One story was from a nurse who said, she was getting ready to intubate a patient, and there was a scare that they had a medication shortage, and she said it came in time and she was able to administer the medication, but she said, what would happen if I did run out of the medication? I can't even imagine. And so that caused her some significant anxiety, just thinking about what would happen if that was actually a shortage. And they're experiencing trauma, frankly, fear, anxiety, and trauma going into battle day after day after day. And the younger nurses weren't necessarily as prepared. I actually learned a lot myself, just in terms of, an emergency room tends to have younger nurses. And one emergency room doctor was telling me that he was very concerned about their mental health, because they're just not used to having just talked to somebody and then they die on you, and saying that the nature of the disease and the sort of insidiousness of the disease was really causing significant trauma. And they said it's traumatic to know that I'm not able to save as many people as I want, and to work on them for as long. Another really important theme is grief. So fear, anxiety, trauma, and grief. They're really grieving the fact that they're not able to save everyone, that they're not practicing as they were before. They're grieving the loss of a coworker. They're grieving the fact that coworkers are catching the virus in general. It makes them think about their own mortality. The loss of family members. So they're grieving the fact that family members can't be there. They worry about their healthcare coworkers who are self-isolating at home, and they can't be around their family members. I had many people tell me that I should study the impact of COVID-19 on the mental health of family members. And having to say, and this was somebody from a nursing home who said, I had to tell somebody who had been married to their spouse for 40 years that they actually can't come see them. It's heartbreaking, and it was heartbreaking for them to know that somebody who's in their 30s or 40s, they were told that they have to ask them before they were intubated to sign a do not resuscitate order. And so the grief was really profound. It was palatable, and it absolutely concerns me that we've got to help our healthcare workers get the grief out and process it, or we're going to be in a position of possibly some prolonged grief. And what we find, what was pervasive as well, is that most of the nurses and the doctors said to me, you know what, we're tough. This is what we do. This is, this is why we got into medicine, to have this impact. But we all have to recognize what we've lost, and grieve it and get it out. So really, really profound in this theme, I think. Go on to the next slide. So I asked about mental health techniques. Are there things that you're doing today that are helpful? And are there things that, we could help put in place that would start to mitigate some of this mental health trauma? And they all did talk about, what, I have to vent. It's camaraderie with my coworkers is great. I did have one person tell me, though, that, you know what, it's great to talk to my coworkers, but it's really nice to be able to talk to you, who will just listen. And so that kind of made me think that, it might be nice to make sure that folks have a third party, so they're not sort of fighting for airtime, and they can just vent and just get it all out, and to that third party. One of the things I thought was really interesting was our spiritually based hospitals had chaplains going around and helping and sort of creating an element of support, pulling folks into a room and having a conversation. And folks said, I wouldn't normally talk to a chaplain, I'm not religious, but just having that extra support was really, really helpful. And again, they tend to power through. So what we learned was that if my employer puts it in front of me, I probably will think about it, and I might recognize that there are risks. And most of the nurses were really clear with me that they have to be told that they're at risk. Otherwise, they'll just keep going, and they worry that the risk will catch up with them. And they talked about exercise, some self-help stuff, but really it was all about venting. And you know what, if you put it in front of me and give me the information that I might be at risk, I'm going to be more likely to act. All right, we can move on to the next slide. Above all, everybody said this job is a calling. And, again, amid all the chaos, this reminds me why I went into medicine. I still love going to work. This is what I do. It's a calling. It's not a job. And we heard that over and over again, which really leads us to believe that if we can provide mental health intervention and mental health support going forward, we're going to have engaged frontline healthcare workers, and we're going to be able to ensure that they continue to do the work that they so love. We can move on to the next. One big theme, we talked about management a lot, and what happened at the beginning, what happened in the middle, and we did this study back in March, so it was pretty new. And we got through it in April. But we really found that management makes a huge difference. And it was really about, will they support you and feel like, will you feel like they have your back? And I heard over and over again that that's going to make all the difference. And if management was perceived as not being supportive, the anger that came forward was palatable. It was, it seems like they don't care, I'm uncomfortable. It definitely perpetuated anxiety, and, ultimately, words like irritability came out. I get irritable every time I have to go to work. They're just not there for us. I don't know what to expect, and I don't think I have the support. Management, if supported, had an amazing impact, where folks said, you know what, I still love my job. I don't fear coming to work. I know they will have our back. Having resources on the floor was a really big bonus for folks, where they felt like, geez, if there's somebody here with us, willing to answer our questions and willing to support us, that really went a long way. And the biggest piece of advice that folks said was deeply listen. Make sure that you hear us, walk with us, tell us thank you. That's what will lift us up. Somebody said, I just need to know I'm heard, and they see me, they know I'm sacrificing, and those are the words that will lift us up and keep us going and help us feel supported. go on to the next slide. All right, so with that, I'd love to turn it over to Dr. Leschke to just sort of give his insights and his thoughts on the study and what our workers are facing with COVID-19.
Hi, thank you, Dr. Tugman. That was very informative. There's so much great information in those slides. A lot to digest from your study. And from my perspective as a peer coach, I mean, that is very reflective of what physicians are coming to me as a peer coach to talk about, was all of those things that that you mentioned in your study. But we want to hear from you again. We have another poll question. This one is more geared towards what you are facing individually. What is your primary concern? I know there were less physicians on this call, but for everybody, you don't necessarily need to be a healthcare provider to answer this question. And while we're waiting for the responses to that, I want to mention something that Dr. Tugman had said about having that third party. It's been one of the great things about being a peer coach is having that opportunity to talk to people who I'm not working with. They have that additional person to share their experiences with. And oftentimes when we're trying to solve problems, we're trying to put the same keys into the same lock. And sometimes working with that third party can really help you discover new keys in ways to solve the situation that you're in. So let's see. I can't see the results of the poll. Maybe there we go. Okay. Yeah, all right, so we have the biggest percentage, stress and anxiety, followed by that heightened fear of getting the disease yourself or bringing that home to the family. Certainly, that's I've heard a lot of that, especially in clinicians who are at risk or who pose a greater risk of having COVID or who have family members who might be at greater risk. And there have been a number of clinicians that I've spoken to who have had to make decisions about, should I stay in a hotel? Should I be isolating myself from my family while at home? And the feasibility of that. How will we be able to sort of manage that depending on how long this goes? Financial concerns were certainly in there, and that was reflected in the organizational poll as well. And yes, that's been a big concern in some of the clinicians that I've worked with. Their clinics have closed. They are being reallocated to other departments. Some folks have been furloughed. And so financial concerns are a huge part of this, especially in some of those physicians who perhaps might have been ready to retire or getting close to that. And now with the economy and now potentially with decreased revenue at work, they're sort of feeling stressed about that. I mean, all of that is to say that, the important thing to remember is that, our jobs at baseline are difficult and stressful for lots of various reasons. And sometimes we need to be able to admit that. And one of Dr. Tugman's points was that we like to power through, right? We say, this is why I went into medicine. This is what I'm here for. This is part of my job. Well, that might be true, but more likely you're struggling with something new, managing the constant changing of information. Is this protocol what we were doing last week? Oh, now that's not working this week. So, how do I manage that? Or things that we would normally do for our patients that perhaps we aren't doing now because of COVID, because it puts everyone in the room at greater risk. So managing that dissonance and the constant changing of information has been very difficult. Changes in our job environment can have a big impact on our overall well-being. And the reason for that is because it changes how we value or what we value about being a clinician, and how we find meaning in our work. And that has run the gamut in my experience with my clients, which is, some are in hotspots, and so they're doing much more work or seeing more acute patients. They're experiencing that grief of having to deal with that experience. And then on the other spectrum, there are physicians who are seeing lower volumes, and they're stressed about that because perhaps their clinic is closed, or there are furloughs, or revenue is down. And then the dissonance. So some folks in the hotspots who are sort of experiencing perhaps being frightened, or maybe not necessarily wanting to be working in that environment, and the guilt that comes with that, because everyone seems to be wanting to pitch in. Why am I, scared about that, or why do I want to step back? Again, on the other spectrum, folks in those lower volume places who, feel guilty that they are not seeing those volumes. Or I had one client who said, I just feel like I should be getting in the game. And so having that guilt of seeing colleagues perhaps in other places or other departments working harder when they are not. And so, all of that information just shows that we all have a different experience. And so I know there are a number of administrators on this call. And so while it's great to be putting a lot of resources in place and offering those things, I think it's important to remember that sometimes one size doesn't fit all, and we all have our own experience in this pandemic. And so having a wide range of resources and encouraging each other and encouraging our clinicians to talk about what's been hardest for them the most, and seeing that it's different for everybody and that we can support each other in those differences. I really liked that comment from one of the people that was surveyed, that, I don't worry about myself, I worry about other people. And that's so classic with clinicians, especially physicians. We put our patients first, our colleagues and our families second, and then ourselves last. I mean, we know that from previous studies. And so if we can not only say, hey, there's a lot of resources out there, but encourage people and say, we're gonna create a structure where people can say, you're going to use this resource, or let's have you use this resource. Let's put you in touch with a peer coach or an EAP or a support group to sort of normalize that, because we think that if we use those resources, then there won't be enough available for someone else. I mean, that's just not true. Sometimes I have to tell physicians who have this mindset that they're very worried about other people and not themselves. I like to tell them, like, well, if you model that behavior of accepting help and expressing your vulnerability or what's stressing you out, well, then someone else might do that same thing. So you're actually helping other people by doing that. And sometimes that's the thing that gets them to utilize resources. From a leadership standpoint, I think part of the problem is oftentimes there may be a strained relationship with leadership already. And I think it's just important for everyone and for leaders to just step into that discomfort, lean into that, and talk about it, so that we can, like Dr. Tugman said, discover what sort of support you need, be present in that support, and show up as leaders. And I like to help physicians who are expressing a discomfort with leadership to say, okay, well, what specifically do you need? How can you perhaps step up to help fill those gaps, or how can you communicate that to leadership in a productive way? So mostly when I'm working with clients, I just like to express it's okay to admit that your situation is less than ideal for you. It's good to think about and create boundaries for how you want to live and work. And then, working with an outside person can help constructively think about how you want to control your situation as best you can, and how you want to strategize ways and take action to create the work and the life that you need and want. So those are my experiences. And I think now we have some time for, oh no, there's some recommendations from the study. Sorry, I'm going to throw it back to Dr. Tugman. Back to you.
Hey, no problem. So thank you for that. That's I appreciate your insights, because it really is right in line with what we found in the study in terms of how management can support folks most effectively, and then what folks need in terms of sort of the push to say, hey, it's okay to not be okay, and to reach out and ask for help. So ultimately, when we think about management recommendations, as we tie them to the study, being visible and being present, so important. That just went a long way. When I had somebody say, I just want them to walk with me and really understand what we're dealing with, what's happening. And that was from the top down. So that meant not just a nurse manager, it meant the CEO actually stepping foot on the floor and being willing to demonstrate that level of support. Simply saying thank you went a really long way. And I apologize if you can hear my dog, but that's sort of the danger, I guess, the hazard of working from home. So sorry about that. So say thank you. That went a long way. There are actually folks who said, nobody's ever said thank you. Nobody's ever said thank you for doing what you do and coming in specifically. It was somebody who worked in a nursing home who said, I'm putting my life at risk every day, and nobody's acknowledged that. And again, we talked about walking with frontline workers. One of the things was communicate. We really can't emphasize that enough. Even if you don't know anything in management, in terms of, I don't know if we're going to have enough PPE tomorrow. I don't know if our policies are going to change next week. Just let folks know that. They said it's so important. That transparency just makes us feel like you have our back. And then be honest and be clear with what's the plan, and be clear. It might change next week, but this is what we're doing right now, and this is what we're going to stick to. They all talked about feedback and listening, and so listening was, there were kind of two forms of it. Listen to what we're going through, but also listen to what we know will work. Our frontline workers are in the thick of it. They've tried things. They know what has worked, what hasn't worked. And most said that, right at first, because everybody was caught off guard, that management just said, this is what we're doing, go do it. But as things have evolved, most said, they're willing to take our feedback. They're willing to admit that they should have initially. But again, it's really important to feel heard, because they are on the front lines. Offer those mental health resources. They're going to trust you. They're going to trust that you're providing resources that are going to be effective. And ultimately, as both Dr. Leschke and I have said, they're going to power through unless they're told flat out, you're at risk and it's okay to not be okay. The debrief sessions were huge. Having that third party, like Dr. Leschke was talking about, in terms of that coaching, that's going to be essential, just to allow people to get their trauma out. And I worry about empathy fatigue a little bit, because there are going to be some long-term ramifications that we're going to all need to be patient with folks, because we don't know how the grief, the fear, the anxiety, and the trauma are going to manifest over time. Go to the next slide. And we'll talk a little bit about immediate mental health needs. And so, again, make sure that we're communicating specifically what resources are available. Make sure that you're talking about the coaching that's available. Make sure you're talking about specifically the interventions that are available. You know, have group exercises. You know, I actually had one physician say that he calls sort of his debriefs a medical minute, and they all sort of get together before and after the shift to debrief, do some breathing exercises, and just be there to support each other. And you know, again, it's really all about advertising and being transparent about mental health in terms of it's okay to not be okay. And I can't emphasize that enough. Frankly, in every workspace, we should be emphasizing the fact that it's okay to not be okay. It's okay to reach out. It's okay to raise your hand and say that you need something. We can move to the next slide. And a little bit more in the long term, we realize again, you know, the key themes out of the study, in my view, were everyone's experiencing fear and anxiety. They are going into battle day after day after day and experiencing trauma. I had somebody say, you know what, we're living out this trauma every single day. And so I said, well, what do you worry most about? And she said, I worry about post-traumatic stress disorder. And so again, we don't know what the long-term effects will be, and our folks are experiencing that trauma and that grief. The grief was really pervasive, as they talked about not being able to be there for patients, not being able to be there for patients' families, being separated from family, not being able to intervene and treat folks and save folks' lives attempt to save folks' lives for as long as they're used to. And that was all heartbreaking. And so that's grief. And so if we don't really recognize that the grief exists and process it in the long term, we're at risk of prolonged grief reaction that leads to depression and anxiety. We have to raise awareness about warning signs. And, you know, I think that comes down to training and making sure that folks recognize the warning signs of post-traumatic stress disorder, of anxiety, of depression, and know when to act and know when it's gotten to the place of being pervasive. It's important for managers to be trained to understand when somebody has symptoms that might appear to be a performance issue, but really it's an emerging mental health condition. So we really need to be proactive, provide mental health screenings, and then have attached to those mental health screenings resources available to begin that early intervention treatment. And again, in the long term, just like the short term, we have to listen and validate. This is a traumatic experience. And again, I worry about empathy fatigue, but we've got to really fight it, and we've got to continue to listen and talk and validate the experiences. We can move on. So just quickly, I kind of wanted to share the warning signs of post-traumatic stress disorder. I think, you know, this is sort of the worst case scenario, but we know, again, one of the things that concerns me most is that notion that we've talked about throughout the discussion is just sort of powering through. And so what that means is the trauma that is still being experienced, even though one is powering through, is not being processed. And when trauma is not processed, that's when we're at risk of post-traumatic stress disorder. And so we just want to make sure that we're aware of the symptoms. It can manifest as depression and anxiety, and that's fine. We just need to make sure that folks get into proper care. But I think it's important to recognize that post-traumatic stress disorder is a little bit different. As folks sort of move into that space, they tend to be a lot more negative, irritable, tend to even be self-destructive, difficulty concentrating, significant sleep disturbance, may even forget aspects of the trauma. And so what that really demonstrates is that they've not necessarily processed the trauma. And that's why we've got to make sure that we're providing those outlets and talking and, allowing for that grief to be processed. We can move on. The other thing we worry about is stigma, right? So, we talk about powering through, and we talk about that, I was made for this. I was born to do this. I was born to help people, and this is my calling, and this is who I am. And so I should be able to handle this. So I think that there will be self-imposed stigma where I should be able to handle this, and I should just, keep going. It's who I am. It's what I do. And so we have to make sure that we're promoting mental health in the workplace, that we're creating parity. So if we're promoting things like Heart Health Month, we want to make sure that we're also promoting Mental Health Awareness Month, and we're promoting National Suicide Awareness Month. So sort of equal support for health concerns as well as mental health, and really, making sure we're having the conversations around mental health. And so while I worry about self-imposed stigma, we still have stigma relative to mental health in our society and in our workplaces, where folks say, well, geez, I'm stressed. So I don't really understand why, Bob can't get over it and just come back to work and be okay. And so we talk a lot about how, we'll get through this, we'll be resilient, we'll be better for it on the other side. But ultimately, we are experiencing grief, trauma, every single day, and fear and anxiety. And so some folks will need that extra help, and there's nothing wrong with that. And we have to just continue to emphasize that, again, I'll say it again, that it's okay to not be okay. And that's how we're going to reduce mental health stigma and get folks to feel like it's okay to raise their hand and ask for help. Okay, we can move on. All right, I think I'm going to turn it over to Liz to take it from here.
Thank you, Dr. Tugman. And I'm just very briefly going to shine the light on physicians as we think about these frontline workers and their mental health and well-being, and how they can access help. Stigma that you were just talking about, for sure, that's a huge barrier for physicians when it comes to accessing help and care for themselves. And it's interesting, in 2017, we conducted a survey, and among other things, it was a national survey of physicians and actually advanced practitioners as well across the country. And among other things, we were interested in knowing what kinds of well-being solutions and services were most valued. And beyond that, what barriers might clinicians say that they have to accessing these resources for care? And so what you can see here is this graph, the type of barriers participants were experiencing getting help for themselves, and the percentage of respondents that identified each of these barriers. And I want you to know that over 50% reported 6 or more of these barriers to seeking help. Time was huge in terms of what got in their way, just simply finding the time. This was in 2017. I think it's even greater for many clinicians now with COVID-19. The productivity demands, wanting to make sure that they were making the expectations of productivity, having access to solutions. Again, stigma huge, awareness of what works. Next slide. So I think with that in mind, we encourage you to consider some of these steps as you develop and offer solutions for support for physicians. Time-saving solutions obviously are very important. Having resources at their fingertips, like a mobile app, something that they can easily access and find resources for care. Ensure in-the-moment support 24/7. That might be for the virtual concierge. It might be for in-the-moment counseling, perhaps even for peer support. Having peer support available, being able to talk to other clinicians who understand the challenges that they're facing and who can get right to the heart of the matter can be a very important solution to offer. As well, if you're going to have mental health counselors, make sure that they're people who understand the unique challenges that healthcare workers, particularly clinicians, are facing. If you call out that your program and your services are for physicians or for advanced practitioners, you are much more likely to see them utilize these services. As Dr. Leschke was saying, there's a tendency to think, well, this is for someone else, and I don't want to use up a resource that someone else should be able to access. Again, if you can offer services outside of regular clinic hours, great. You could train well-being advocates throughout your organization to be able to carry information on well-being and the resources that are available. All the more likely that people will know and won't have to seek or search out what's available for their support. So I think we've got up to 10 minutes for question and answers, and I'll ask Dr. Leschke and Dr. Tugman to join me, and I will take a look at what questions have come through from our participants. Here's one question. I think this would be for you, Dr. Tugman. As COVID-19 continues, are you hoping to revisit this study or do a longitudinal study to review the impacts of COVID-19 on healthcare workers over a longer period of time?
We are actually. That's a great question. Yes. So, you know, the mental health crisis is definitely evolving, and so we've started some work to really understand what's happening in society from an anxiety and depression perspective around all the sort of the perfect storm of what's happening from economic downturn associated with the pandemic, the slow reopening of society, as well as the racial unrest and injustice that we're experiencing. So, you know, there's just so much piling on. Next step is definitely, once we can sort of observe how some of what we're implementing within the healthcare world is, how that might be working and sort of acting as a preventative measure, and how effective it is from a treatment perspective, we'll definitely be revisiting. I think one of the things I'd like to look at, well, two things, is the anxiety around, we heard from a lot of folks that when I asked the question, what are you worried about? And they said, well, I'm worried about, you know, experiencing trauma, post-traumatic stress, and what that ramification will be. But also, I feel like we're all going to be sitting around waiting for the other shoe to drop. We're not going to trust that wave 2 isn't coming, and we are not going to trust that our PPE today, as a result, is really protecting us. So I think that's an area that we really want to focus in on. And then I think family members as well of healthcare workers, as well as how, you know, potentially feeling like you're either infecting your family member or had to be isolated from your family member, how that also impacted the healthcare worker.
Yeah, and I think
Thanks for that question.
And the uncertainty that Dr. Leschke talked about, constantly changing information and protocols, and the stress on workers, and certainly how that impacts mental health. Here's a question: with COVID expected to be long haul, when will PTSD start to be seen in clinicians?
Well, I think, you know, we have studies that show they've done studies in like critical care units like ICUs and emergency departments, that there already is a significant level of PTSD at baseline, and so I think that's probably already started. And I'm sure that Dr. Tugman would probably agree, or that probably came out with her interviews. So I think it's here already.
Absolutely. You know, I think, and we don't, PTSD really can also manifest years later. So we don't really know what the impact will be. So I 100% agree that it's already here. But there likely are folks that are, you know, sort of staving it off and continuing to power through, that will be impacted for years to come.
So another question: you offered many suggestions for leaders on how they can assist the frontline workers, but what does one do when they're, I'm kind of paraphrasing this, what does one do when they find it difficult to hear the kinds of things that their workers might say to them, when they realize they don't have answers, right? And that makes them uncomfortable actually reaching out to their workers. How do you get past that discomfort?
Yeah, I mean, that's something we deal with all the time, especially in the mental health space where managers don't know what to say. They're not comfortable not having all the answers. They kind of look to themselves as being as being required to always be that level of support or be that sort of all-knowing being, which we know is not, it's just not realistic. And so as we and on my team work with employers, we sort of try to pinpoint, talk to me about your management team. What would they say in this instance? Would they be comfortable having a conversation with their employees about the uncertainty, about the fact that this is hard? And most of the time, the folks that we talk to say, nope, they would not be comfortable. They don't know what to say. They don't know what to do. They don't know how to intervene. They're worried about saying the wrong thing. And so that's when I, highly recommend that we do manager sensitivity training, in partnership with human resources, and really talk to them about, here's warning signs, here's what to say, here's what not to say. Make it really concrete. Here are some effective ways to communicate, and really, help managers have the tools that they need to be that people support versus just that technical expert.
From a physician standpoint, we always teach clinicians, the patients that you least want to go back and talk to are the ones that you actually need to talk to more. So if you are feeling a need to avoid that situation, that's probably your indication that that's the situation that needs you to be there, that needs your presence and needs your time. And sometimes, like Dr. Tugman said, it really is just a matter of being present and listening. That perhaps people aren't necessarily looking for a grand solution from you. They just want you to know that you know what's going on as the leader. So walking with me, see what my work environment is like. So then when you are in your office or board meeting or whatever meeting, you have that experience that will inform the decisions that you make next. So lean into those uncomfortable moments, I would say.
Absolutely. And I always say, if you're going to do that, if you're going to go and be seen and walk with those who are providing the care, make sure you always tell them why you're there, because there's a tendency to think, oh, you're there checking up to make sure we're doing everything right. What you don't say to people, they will make up their own explanations. And I think all too often, if they don't see their leaders reaching out and showing some presence and interacting with them, their explanation for that is that you don't care, is that you simply don't care, that you don't think that they're worthy of the time. And we know that's really not the case. In all the leaders that we talk to, we know that you care. We know you're concerned. But I think it's not an assumption. You wish that everyone on the front line would make that assumption, but they don't. So I think finding a way to share that is really important. Let's see, one more really quick. Someone talked about a variety of things, but at the end said, one of my recommendations is for senior management to focus more on the lives that are being saved than those that are being lost. That can be offer more hope, and wondered about your thoughts on that.
Yes, I'm a big proponent of celebrating every win, and it doesn't have to be. We don't have to wait to save a life to celebrate. We can celebrate absolutely every little thing, 100%. And yes, if we focus on the positive, plenty of positive psychology studies that talked about the power of positive thinking, the power of pointing out the positive things, being grateful for all the good things that are happening. So yes, celebrate everything.
Thank you so much. We're really at the end of our time, and I want to make sure that you get a moment to look at the contact information here. And I know that our speakers would welcome your questions or your feedback, and so feel free to reach out. We will be sending out a link to this webinar, and it is posted on our YouTube channel. And we just thank you all for having joined us here today, and particularly thank you to Dr. Tugman and Dr. Leschke. And thank you. Have a good rest of your day.